Good morning, everybody. Welcome to the Healthcare Services Review Project Committee meeting for January 17th, 2024. It's 8:31 and we'll get started. We have some remote participation today, so prior to roll call, I need to read a statement and do some housekeeping matters. So prior to roll call, I would like to make it clear for the record of this meeting, and it should be reflected in the minutes, that at least a portion of this Healthcare Services Review Project Committee meeting is conducted pursuant to California Government Code Section 54953, and that committee member, Chris Zuniga, is at an alternative location of 4860, El Dorado Drive, Laverne, California. Committee member Zuniga is participating via Microsoft Teams. In accordance with the Ralph M. Brown Act, each alternative location has been identified in the notice and agenda for this meeting. Kristen Santo, can you please conduct roll call? And after which I will ask committee member Zuniga to recognize me in order to confirm certain matters for the record. Thank you.
Supervisor Canepa.
Here.
Supervisor Dean. County Administrator Wilverding. Ms. Hopkins.
Here.
Ms. Vanstein. Here. County Counsel Kiernan. Ms. Macedo? Here. Mr. Wolkamp? Mr. Diederich?
Here.
Mr. Castro? Here. Mr. Nunez? Here. Mr. Zuniga?
Here. Thank you, Ms. Santo. I would now like to request committee member Zuniga respond to the following questions. We have about 5 questions, Mr. Zuniga, just so you're aware. Mr. Zuniga, can you hear me well?
Yes, I can.
Were you able to hear our proceedings on this end up until now?
Yes,
Do you have a copy of the agenda for this meeting?
I do.
Have you posted the agenda at the location where you are at?
I have.
And thank you for sending the picture. Is your location reasonably accessible to the public such that any member of the public could participate in this teleconference from your location if they wanted to do so?
Yes.
And last question, is there any member of the public there with you who would like to participate in the public comment portion of this meeting or otherwise address any agenda item for this meeting?
There is none.
Thank you, Mr. Zuniga. I would now like to ask that any member of the Healthcare Services Review Committee, Project Committee, speak up at this time if such committee member has not been able to clearly hear Committee Member Zuniga. Hearing no comment, the record should reflect that all committee members present have indicated they were able to hear Committee Member Zuniga clearly. We have one last admonishment, and then we'll move on to the agenda. I would next request that any committee member speak up at this time if such committee member has any reason to believe, based on voice recognition or otherwise, that those persons representing themselves to be committee member Zuniga are not truly so. Okay, looks like we're good. Hearing no comment, the record should reflect that no committee member has expressed any doubt that committee member Zuniga is the party participating by teleconference with committee members present here. I would now like to advise the committee members that any votes taken during the teleconference portion of this meeting must be taken by roll call. So our first item for business is to approve the minutes from December 20, 2023.
Supervisor Canepa? Your vote to approve the minutes?
Yes.
Ms. Hopkins?
Yes.
Ms. Vanstein? Mr. Kiernan?
Yes.
Ms. Macedo? Yes. Mr. Diedrich?
Yes, with the amendment I sent via email. Thank you.
And to clarify, that amendment was to add you on as present and as approving the minutes. So we did submit a revised agenda to include that reflected in the minutes. Mr. Castro? Yes. Mr. Nunez? Yes. Mr. Zuniga?
Yes.
Thank you. We will now move on to information and discussion items. Our first discussion item is the presentation of the 2023 financial results through November for our county clinics, and Mr. Zuniga will be presenting. He's going to share his screen as well.
Okay. Can we see the title screen?
We can, thank you.
All right, great. Okay, so today we are reviewing the results of November 2023 for 17 health centers. We begin our examination with I'm stuck, and there's a bit of an echo, but if I'm hearing that, that's great.
There's not much of an echo on this end.
Okay.
Mr. Zuniga, may I pause you for just a second? I think we're having a technical difficulty. Let me check with our IT team. Thank you.
Your call cannot be completed as dialed. Please consult your directory and call.
Thank you, Mr. Zuniga. So we're going to move on to our next discussion item. It's the presentation of the 2023 financial results through November for San Joaquin General Hospital. And Mr. Nunez, our hospital's Chief Financial Officer, will be presenting. Abe, your microphone. Thank you.
Yeah. Good morning, everyone. I'll start. So we're 5 months into our new fiscal year. As we approach the midpoint of our year, we're starting to see some similar trends when we look at our key volume metrics along with our revenue and expense lines. I do want to point out that for the month of November, we did achieve our operating margin target, largely due to a pickup in our inpatient business. We did see higher patient days and discharges for the month. With that said, from a year-to-date viewpoint, we're still not where we expected to be from a net income or net loss, in this case, perspective. So when you look at our financial results overall, our net loss is hovering around $4.4 million, so we're short of target by $1.9 million. Looking at our performance from a cash flow or EBITDA perspective, we're short of our expectations by $1.3 million. Do want to point out that we feel pretty comfortable realizing some opportunities as we close out the fiscal year that will get us closer to our budget here. But we'll go over some of those potential pickups towards the end of the presentation. Looking at the volume metrics for the whole house, so our adjusted patient days, which is our inpatient days plus outpatient equivalent days, we're short of budget by a little under 1%. Our inpatient business has been down relative to budget from a year-to-date viewpoint, in particular on the adult side. So our patient days and discharges are down. With that said, we have seen considerable growth in terms of our maternal child service line. Our deliveries are trending in the right direction for us, along with our trauma cases. Our surgical volumes have been strong all year, which is really helping lift some of our ancillary departments when we look at lab, imaging, our pharmaceutical charges. So positives there. Looking at, we've talked about previously about the launch of our Clinical Documentation Improvement Program, so the CDI program. We're starting to see those gains now when we look at the case mix index or acuity level of our patients. So we're coding our claims more appropriately, which is lowering the denials from our payers and increasing our revenues, in particular when we look at our Medicare and CDCR patients. So positives there. Looking at our operating revenues overall, we're about 2% above budget, or $3.2 million. So while our inpatient business has been down, we've made up for it when we look at our outpatient surgeries, deliveries, trauma cases. So we've been able to find some offsets for that volume contraction on the adult inpatient side. And we've talked about the quality metrics around our supplemental payments not being where we need them to be. So we're being more kind of judicious in how we recognize those revenues connected with some of these programs. On the expense side, when you look at our overall cost, we're $5 million over budget, or 2.5%. When you break out the budget variance by expense category, what you're going to find is that it's all under the professional fees line, which is our travelers. So while we have seen a decrease in our contract labor of about 20% year over year, we're not at the budget level in that we established a very aggressive target in terms of those traveler reductions. So still opportunities to get back to a pre-COVID state in terms of those contractors. And just looking at our overall costs per CMI adjusted discharge, which is kind of evaluating our overall cost structure, we're actually running favorable to budget in that while we're seeing less inpatients, they're more complex. So they're carrying a higher case mix index, which gives us credit when we look at this cost metric. So here's a snapshot of our income statement. Kind of hard to read, but for the month, you'll see that our loss came in at $480,000. So we were projected to lose $510,000. So we beat budget by $30,000 from a net income perspective. Looking at EBITDA, we actually were favorable by $148,000. And year to date, net loss is at $4.4 million or $1.9 million lower than expected, and our EBITDA or cash flow results are $1.3 million lower. And then here's the more granular view of our income statement. When you look at our gross charges, we're 2.7% above budget. Net patient revenues are 2.2 million or 1.6% above budget. We are seeing a considerable shift in our service mix from inpatient over to outpatient. Those outpatient services carry a lower collections rate. That's why there's a delta there between the gross and the net patient revenue rates. Down on the expense side, I mentioned we're $5 million over budget through the first 5 periods. When you focus on the professional fees, which is the second line down on the expense section, we're $6.6 million above budget. So I know the nursing teams there are doing an admirable job finding ways to reduce those travelers. With that said, because of that aggressive target that we established in this year's plan, we're still hovering above that expectation. And here's a balance sheet. The one item to note is that our cash balance has decreased by about 24 million for where we ended last year. That's largely due to the timing of when we have to put up the intergovernmental transfers connected with our supplemental payments. So we put up the transfers, and then subsequently we get paid the federal matching funds from the state and CMS. So we expect our cash balance to pick up here as we get those payments back. AR, our AR days, we still have considerable improvements there in terms of bringing down our receivables. Meeting this afternoon with our billing and collections team to come up with a strategy to get back to where we ended last year. But yeah, definitely have opportunities in that space. And then another reason why our cash balance is down is due to the fact that we've reduced our accounts payable liability considerably when you look at the liability section. I'm gonna skip this one here. So here's some key volume graphs. On the top, you'll see our inpatient adult graphs, so our patient days and discharges. Blue line is current year, budget is red, and then green is prior year. So you'll see that in the month of November, the blue line did pick up both, when you look at days and discharges, which was really the key driver for us achieving our margin target for the month of November. But overall, for most periods, you'll see that the blue line, which is actual, is lower than where we ended last year and the targets that we established. And down below, when you look at our length of stay, we're pretty much where we expected to be in this year's budget. We said, I think it was a 3% improvement target in our patient throughput. So we're achieving it, but we still feel like there's opportunities in terms of discharging our patients earlier in the day and opening up a bed for a newer patient. And then looking at our deliveries, bottom right-hand corner, you can see that the blue line or current year has consistently come in higher than targets. That's a positive there. Here's some additional volume graphs. When you look at the very top graph, which is our surgical volumes, you can see that the blue line actual has consistently exceeded budget and prior year level. So that's important for us since these cases are driving our ancillary charges up. And then down below, when you look at our trauma cases and our ED visits on the right, trauma cases, we did see a pickup here over the last couple of months, but for the most part, we've exceeded budget. And ED visits, we expect those to pick up as we progress here through the winter flu season, but overall, we have seen some contraction in our ED space. So here's a couple of graphs connected with our billing and collections. Top graph shows our PFS collections comparing current year versus prior year. Overall, we have seen those collections pick up by about 1.5%, but we're really focusing on ensuring that we're collecting every dollar that we're entitled to by our payers and finding ways to minimize denials and reduce our AR days, since when we look at our fee-for-service revenues, that makes up 75% of our revenue line. And the revenues we book on our income statement are only as strong or as the cash collections that hit the door. So definitely there's a big focus to ensure that we're finding opportunities to enhance these numbers. And here's the days cash on hand. Similar to our cash balance on the balance sheet, we have seen a decline due to the timing connected with our supplemental payments, but we expect our cash balance to be replenished here in the next quarter. Here's a graph that measures the acuity level of our patients or case mix index. You can see a considerable pickup in the CMI, which again is helping drive our revenues up for our government payers, and minimizing denials with our payers now that we're coding our inpatient cases more and more correctly. And here's our chart that measures the overall cost structure for the hospital. So it takes our cost per discharge normalized for acuity level or CMI. It's a metric that hospitals look at to kind of benchmark and compare their cost structure relative to other similar facilities in size. And overall, you could see that last year we ended at $15,500 cost per CMI adjusted discharge. This year we're actually lower. We're at $15,181. So while we're getting hit on the expense side with higher inflation, due to the fact that we have seen a reduction in our travelers' expense, we've been able to see some improvement in that metric, along with the higher case mix index, which is factored into this calculation. And here's a graph that highlights our contract labor. So comparing this year versus same time last year, if you focus in the month of November, you could see that our travelers last year were at 165. This year they dipped down to 130, so that's about a 20% reduction. And we're seeing those lower costs now hit our income statement as well. And we'll share that slide here shortly. But when you look at which departments are driving these travelers, there's 10 areas really that we need to focus on. Those 10 departments make up 80% of those contractors. And here's the financial impact of the lower traveler FTEs. You could see that during the COVID period, obviously hospitals were hard pressed for resources. So our contract labor skyrocketed in 2022. We were at $82 million that fiscal year. We came down to $63 million last year. And this year, when you annualize the numbers through the first 5 months, we're projected to come in at $48 million. So again, that's a 20+% reduction year over year, which is in sync with the lower traveler FTEs. But again, we definitely are going to continue to focus to try to get back to where we were pre-COVID level. But we still feel there's opportunities there in terms of filling vacancies. And then we talked about how our results are not where we would like them to be. We do expect to realize some pickups in the second part of the year. QIP, quality metrics, I know Greg and his team are focusing on ensuring we're not leaving any money on the table connected with that supplemental program. We're in constant correspondence with CAPH. We just got a confirmation last week that they were able to negotiate a 25% increase for one of our supplemental programs, which is the enhanced payment program. That's going to translate to about $4 million in additional revenue annually. So the effective date of that increase is January of this year, so this month. So we'll be able to bring in $2 million in additional revenue for that particular program. We were able to negotiate a 7% increase with the health plan, so thank you, Lizette, for that. So again, that's going to be another lift to the hospital's financials in the second half of this fiscal year. And we continue to progress through the Cerner revenue cycle uplift project, finding ways to kind of automate some of our processes within our billing, collections, and other revenue cycle areas so that the team can focus on the analytics more and ensuring that we're collecting every dollar that we're entitled to, and rationalizing the operations to make sure we're focusing on the high ROI accounts. And then on the cost side, while we are seeing considerable improvements in terms of our travel nurse reduction, we'll continue to focus on that area. There's a new tool that our materials manager director is evaluating that will help optimize par levels within our supply space. We'll have a more automated system in terms of tracking our high-cost supplies in the OR and cath lab. There'll be some productivity improvements connected with this tool, so a lot of positives there. And then reference lab savings, Rick's been heavily involved with this one in terms of ensuring that we're minimizing those costs connected with send-outs in particular. And we're optimizing our lab department so that we're increasing productivity within that space. So I think that's, go ahead.
So just make a couple comments. The reason that we're so far behind on the nurse reduction, if you recall, prior to the year, we were involved in what we thought was going to be a recruitment of 50 foreign nurses. That was baked into the budget. Unfortunately, that didn't happen just from circumstance that we couldn't get them. So that's part of the reason that our nurse travelers are not where they need to be. Again, we've had significant reductions in travelers. We also have hired about 70 new nurses. Now the challenge is to keep the ones that we have. A couple of things that are really important in regards on the expense side. I mean, again, we talk about, the other piece of it is we would be at or above budget if we had better performance from the public funds, and we need to focus on that. That's not a complaint. It's we need that focus right now because we tried last year at the end of the year to make up for it. I believe our performance is significantly below what the other FQs are performing. It's a significant amount of money. You saw that the money there is $20 million. Next year it's going to be even more because they're adding to those pies. It's essential that we do everything we can in all areas. On the other side that really is unexpected expense, and we kind of saw this coming, the state of California allowed the public hospitals to be subject to the missed meals and the missed breaks, and it's become a bonanza at the hospital, and you see it every month increasing significantly. Very, very hard to. We need to do a better job managing it. Those costs didn't exist before. And I'm just going to remind everybody where we stand, and we've been screaming from the top of the hill for the last year now. Our absentee rate is in excess of 20%, actually approaching 25%. And Supervisor Canaba, could you perform your business if 1 in 5 employees didn't show up every single day? We tried most recently to simply coach some employees of the fact that they have excessive absences, and the union came back and said, basically, how dare you? We've taken the sick leave bucket, which is not an accrued expense until it's used, and we've made it a vacation bucket. It's costing us, we assume, somewhere between $10 and $20 million a year. So if you can think from that perspective, there's a reason that my hair's on fire when we talk about these kinds of scenarios, because they don't exist in the not-for-profit world, they don't exist in the for-profit world, and I don't believe they exist in most of the county worlds. So I'm going to continue to bring up what I see as differences from how we have to run as a county versus how the private sector and the public sector run. I don't really believe that we have to do it from that perspective. So I'm going to continue to ask for 2 things as we move forward. I'm going to continue to ask for an absentee policy that has just a little bit of teeth, and I'm going to continue to ask for our ability to flex our staff, which is true for every hospital in the world. So, again, I'll give you the best scenario. Fortunately, our NICU has been very busy lately, so it hasn't been a problem. But there were one time when we had 4 NICU patients and 9 nurses. 4 NICU patients and 9 nurses because we can't flex the staffing. Not true of any hospital in the country. So we're very optimistic still that we can get the budget in this fiscal year. We have a number of things that we're doing that are going in the right direction. but we need some help, and we need some help on the issues that we continue to bring up every month at these meetings. So thank you.
I have a couple questions. Can you explain the cash thing? Either you have it or you don't. Cash is not a.
Microphone, please, CEO.
One of the programs that that are very essential to us is simply this. We send in a bunch of money to the state, and then the state sends us back more money. So right now, we're in the spot where we've sent the money in, but we're not in the spot where the state has sent the more money back.
Okay.
So that's pretty accurate.
Yeah, pretty much. And
Yeah.
there's federal matching funds, so what we put in is lower than what we actually get back. We get back a larger sum, which will replenish that cash balance.
So we put in 20 to essentially collect 30.
Okay.
Yeah,
so
and
there's
that-
the
that's-
variance. Okay,
that's-
'cause
it's
I'm
just-
thinking,
it's
okay,
just
how
that
do you have
timing.
negative cash? I'm thinking,
Yeah,
it's either
yeah.
in your hand or
Yeah.
it's not there.
Yeah.
Right, so, but CAPH informed us end of last year that we had to have a strong cash balance on our balance sheet because a lot of these supplemental programs required us to put up intergovernmental transfer. So we expected this dip, but we'll see the number, the cash balance pick back up as we get back those matching funds.
So it's just under another coconut waiting to come back. Moving
just
the
Just timing,
buckets around.
just timing.
Just timing.
Yeah.
Okay,
Yeah.
and then the other thing is utilities seem to be under budget. If you're at 37%, the variance is constant.
Yeah, so I know the accounting team is doing a more thorough job of ensuring the expenses hit the appropriate expense category so that we can plan more accordingly next fiscal year. With that said, there was an accrual that was missed in the utilities line at the end of last year, which accounts for about half of that variance.
So it's not $1 million, it's only 500.
Correct, and then our budget for this year, it's too low, essentially. We should have budgeted more dollars under the utilities line, so we'll plan more accordingly next fiscal year, so we'll
Because
see.
when
a
your
very-
fixed costs are moving, they're not fixed, you know what I mean? So if you expect something to be fluid throughout the year, and I mean, that's what you're talking with your nursing, I mean, those are the things that hurt you.
Sure.
Is those costs that, you know what I mean, fluctuate, you try to budget, but I mean, you're at $1 million, there's another $1 million,
Yeah, yeah.
unfavorable is what you guys
But there's
call it,
other
which is a
things-
nice word of losing.
There's
money.
other things we're looking at on the utilities spectrum in regards to simply things like lighting and solar and all those things to help to reduce that cost. We
For
know
long-term.
lighting alone could give us significant savings, but what we want to do is make a more of a planned effort for what there has been talk about putting some kind of solar park out there and all that kind of stuff, but just lighting alone, we know we can get some significant savings, and we're looking into that as we speak.
Okay,
So.
perfect, thank you.
A couple real basic questions. Did I understand you correctly? You indicated you've turned sick leave into vacation leave, and if that's the case, is that just so at least vacation's planned, whereas sick leave is not?
No, sick leave is, and the reason sick leave is such a major issue, and again, if you listen to the union's response to an email yesterday, you understand that in their mind, if you have sick leave on the books, then we can't question you when you don't come to work. So if you look at, and the way that this was best demonstrated is we looked at our long-term employees. So if you have a long-term employee and you know sick bank doesn't go away, you expect those balances to continually go up. A lot of our long-term employees have 2 days on the books, which means they're using their sick leave first prior to their vacation, and I want you to understand the difference. So, well, I'm sorry, I don't mean, the critical part of the sick leave is simply this. We had planned for you to be there. You chose not to. The expense now has gone from accrued to actual, right? Because we had to pay the sick leave. In addition, we have to replace the position, usually at premium time. So every sick call costs us 2.5 times the amount of just showing up to work. And I don't think that was ever the intention. I remember early in my career working for Tenet, and Tenet decided the way that we were going to fix this problem was we were going to make the whole bank PTO. It would be great for the employees to say, look, here's a bigger bank for you to take your time off. It provided great employee satisfaction, and for the first 2 years, everybody thought it was the most ingenious thing they'd ever done. And then about year 2.5, people started having illnesses and no time on the books to cover their illnesses. They're different categories. Sick time and vacation are different categories. At the hospital, it's not used as different categories. I don't know about the rest of the county. Is it that the same process for the rest of the county, or is it just the hospital? But it's become a real problem. And again, 25% one month is like, oh my God, right? Say again?
So if you have 25%, then it costs you 60%?
Sure, exactly. But that number alone, that number alone tells a story that we should all be concerned about, right? Typical business runs about, what, 6%? 6% absenteeism, we're running 25?
So it sounds like you haven't officially changed sick leave to be able
We
to.
can't.
Yeah, okay.
We can't, it's a union issue.
Got it, okay.
Yeah.
But it's effectively being
Yeah.
used as vacations, what you're saying.
Oh, no, we didn't.
And even more basic question, what do you mean by you need the ability to flex the staff? What exactly
So,
does that mean?
in most, every hospital I've been in, and I've been doing this for 30 years as a CEO, 28 years as a CEO. In every hospital that I've been at, you staff based on the volume that you receive that day. So for example, you would budget for an average daily census of say 100, and when the census ran at 110, then we'd have to call in extra people and pay premium. And when census ran at 90, we'd have to call people off to make sure our expense remained, in control. In the county hospital, you cannot flex. So when you can't predict labor and delivery, you can't predict any unit. And we're somewhat fortunate that our medical surgical unit, our telemetry unit, and our ICU unit are always at max. But every other unit, when the volume is down, we can't flex staffing. So that example that I gave you of 4 patients, 9 nurses is true, right? Now we try to rotate them throughout the hospital to get things done, help as much as we can, but it's really an expense that we don't need, and more importantly, it's a industry abnormality, right? Because every hospital in California, or at least every hospital that I've ever worked for, has that ability to flex. It's part of what we do. And without that, as a hospital, you've lost your biggest lever to control costs.
I have a follow-up to that. So then when you do flex, so then the traveler number goes down? So it seems like maybe there's a communication problem, with departments that are using more travelers, right?
Well,
So if you
travelers do
flex, so would that help your traveler time, or would that help that's why the union says, because then the people that have, work here.
So essentially, travelers are there to backfill for vacant positions. When volumes dip, as Rick alluded to, your revenues are going to dip as well. So we have to rationalize our expenses, right, our head count, to offset some of that lower revenue. So that's kind of the way of flex.
But we do have the ability, fortunately, because travelers are contract, we do have the ability to send them home. And so we send them home first. It's obviously the biggest bang for a buck. Obviously, we do that. But, I remember days in the hospital where we saw 2 consecutive days of census below 10%. And the third day, we would say we want to see a 15% reduction in every department in regards to labor, because we have to, the two have to match, right? So we don't have that tool here, and it's like I said, I don't know of another hospital.
So the other side of that is that the travelers cover the 25% vacancy rate of the people being not there. So you have to have folks there to cover that.
In our
and that-
clinical areas,
so you're-
correct, yeah.
Well, you can see a scenario where somebody called in sick, we couldn't find help. We call a traveler in at time and a half.
Right.
And now we're talking, $250 an hour for 12 hours.
But it's difficult to improve the culture. Managers get, without having an absentee policy, right? Some of our managers have employees calling in sick every other Monday. So you start losing your good employees when they're having to do extra work, to cover for their coworkers that are not showing up to work.
We had 42 nurses call in sick on Halloween. We had 42 nurses call in sick on Halloween. Is because they wanted to take their kids out trick-or-treating. It's the reason that it happened. There's no consequence. There's no consequence. Christmas is a scary day.
Are there any other questions for the hospital from the committee? Okay, thank you. We'll move on to our next presentation. We're going to discuss establishing the SJ Health MOU Liaison Committee. Director Diederich.
Thank you, Brandy. No actual presentation, but I am thankful after what looks like about 8 months of having a conflict between SJ Health's external counsel and the county counsel's office via a couple rounds of going back and forth between, I believe, 3 teams of lawyers, was able to have SJ Health's chair, Brian Heck, sign the disclosure agreement. I think it's waiting to be countersigned by Chair Villapudua, but that is kind of the gatekeeper to stand up the liaison committee as defined in the co-applicant agreement between the county as the HRSA designee and SJ Health. That will allow that group to then start determining what the recruitment of leadership is going to be going forward. I know as part of our HRSA operational site visit, we had to articulate a plan to them. Ultimately, even though the CEO or project director is a county employee, the process will be this liaison committee working on that issue, the SJ Health Board standing up a ad hoc CEO or project director recruit committee, working with a external recruitment firm, looking at a short list of candidates in coordination with the county, but ultimately SJ Health's board being presented with a minimum of 2 candidates. But I think larger than what that looks like, what we provided to HRSA was a decision I think that this ad hoc committee or liaison committee needs to make. Do we look at a CEO versus a project director? A CEO exists primarily in the 330 FQHC space and the lookalike space where there's generally a government partner, and historically before the prior CEO, it was a project director. So some dialogue with both boards in that regard, because I think that will be a key issue of how we recruit. Are we looking for a CEO or project director? Are we looking completely external versus internal? But that also would come down to COO versus director of operations. But beyond that, this committee will also finally allow us to look at the co-applicant agreement. Does it need, obviously it needs review. Are there needed revisions or clarifications needed with that? Also the SJ Health MOU with the county, where we buy and sell things from county as well as the hospital, and their bylaws. And the members of the ad hoc, or pardon me, liaison committee would be supervisors Canepa and Ding, and then SJ Health board members Heck and Lee, and then myself as interim. Those are the 5 committee members, and I'd like to ask County Counsel Ed Kieran, I think you've stated that this should be a Brown Act meeting, and it just seems kind of untenable. If there's 5 members and I'm kind of the staff, I can only talk to one other of those 4 parties, and really how can I get things done absent having just formal meetings that would be kind of like what we are today, agenda, public input, all for that transparency. But pragmatically, I know in my role with SJ Health as the chair there, we stood up ad hoc bylaws committees, ad hoc CEO search committees, and because they were ad hoc, not fully subject to the Brown Act. So I just, as we work to stand this up, want to make sure that obviously we're compliant, but also that we're going to be successful with the dialogues that need to occur. But I think we're close to getting Chair Villapudua that signed, and then we have an SJ Health board meeting, I believe, on the 30th. Have some dialogue there, but really rolling up our sleeves and how do we now rebuild the relationship, build shared understanding, and focus on the future.
Sure, and we can talk offline and get do a little brainstorming and see if we can't come up with a practical way to address the concerns you have, because I get your point. Of course, I don't write the laws, I just tell you what they are. But we'll see, we'll discuss it and see what we can come up with.
I appreciate it. Thank you.
So as a CEO of the hospital, with something that's so important to us as the FQ, we talk about those metrics on a regular basis. I have two questions. I need to be involved. I need to be involved at least to some degree, so at least from an informational perspective, I understand what's going on there, because it's such a big piece of our revenue, and to be honest with you, with your revenue as well, as we have it defined in this MOU now, even though I don't agree with the way that it's done. That's issue number one, and more importantly, issue number two and again, I'm protecting the hospital revenue here. We looked at a $20 million giveaway last year, and we all, understand that we jumped into this late, and we did the best we could to make up for that. But all FQ things are looked at on a calendar year basis. So what have we done right now to make sure, because you all know that these are take-home tests. These are just a matter of us performing, not a matter of anything different than that. What have we done now to make sure that the QIP money is looking somewhere in the 90 to the 100%, as opposed to the 50 to 60%?
So two things. Even though there is defined membership to the liaison committee, I don't think it's going to be absent staff. And the agreement between the county and the hospital and what we buy from the hospital or sell in the QIP, I think that's all open for discussion, and that would definitely include hospital participation in that. As far as the QIP, we did step on the accelerator the end of the calendar year, looking for gap closure clinics, specifically on mammography and childhood lead screening. Thankful for a partnership with the Health Plan of San Joaquin. We have onboarded our in the month of January, a hired provider and 3 locums. Some of those are mid-levels. Some of the locums will be funded by Health Plan of San Joaquin, specifically looking at gap closure clinics for their HEDIS measures. So I think we have a running start into the next program year, which is calendar 2024. Now that calendar 23 is closed, we have until approximately mid-June to do the final reporting on that, so that additional staff, that business intelligence staff, where you mentioned that we've ramped up, they are the ones working to actually make sure that we can find, document the data that was performed. Was there a childhood lead screening that was performed outside our 4 walls for one of our assigned patients, and can we take credit for that? But the first several years of QIP were pay to play, where you got the money one way or another. I think our team has done a lot over the last couple of years. That was probably not couple years, couple months that was absent prior to that. But I think rebuilding the partnership with the hospital, because this is where we sink or swim together. It's got to be a partnership with the hospital. I would say indeed our QIP scores are probably second worst in the state. So a lot of opportunity there. We have 32 ambulatory measures. I think we're going to be coming in approximately 80%. There's a couple hospital measures. I think there's 6. I think the hospital measures are going to come in at 50%. But across the board, there's opportunities to partner on this, because ultimately it is driving more revenue into the county's health system, the hospital, the clinics, the agency. But I think it's rebuilding partnership and shared understanding. We've got a running start, but obviously some more gaps to close.
I agree with you. I mean, for me, not knowing all this, the more people, the more hands on deck is more valuable to me. And just, I mean, as far as even on the labor side, when we come into negotiations, and it's uncomfortable conversations, I know a lot of the times, but it's the truth and the reality of what we have to deal with. Because if you don't get more competitive going forward, then we're just doing the same thing. What is it? Monotony, doing the same thing over and over again. Insanity. Insanity, and I'm there. So, I mean, for me, learning all this is difficult because I do it for a full-time job, but I'm not in your shoes, so I don't understand it. So gaining breadth and width of what we do and how we do it, I think is important. So I agree with you that, you need to be there, because it's what's kind of sank us all together. and then, but everyone, the right hand doesn't know what the left hand is doing, and I think that causes a big problem. Part of it's communication, part of it's money, because, you know what I mean, who gets the money, and I'm still trying to understand that with quit money. You know what I mean? You need the clinics, and then, you know what I mean, how well have they been ran? So I think we're getting at least understanding of where the shortfalls are coming, but how do we fix them? And it doesn't seem like pivoting is that crazy fast in healthcare, because, you know what I mean, when you don't have enough patients and their lines are dipping, that was my question earlier, is how do we get those up? What are we doing to get those up? What's the strategies? And so that would be informative to share. Thank you.
I'm glad we have Lizeth, CEO of the health plan, here today, because I think ultimately it is a partnership, a 3-4-way partnership. The SJ Health just received notice of a little bit more than $1 million from the health plans for improving some of their HEDIS MCAS scores. Those are measured a little bit differently. We have to meet the minimum performance level, which is the 50th percentile of our peer group, versus QIP. Every year, in order to get incentive payment, we have to be 10% above where we were in the past year. But I think to Rick's comments, there are other health systems that are 100%. How can we get there? Because this is not only just more incentive program money, it is a proxy for better care, better patient outcomes, and something that we all have shared and aligned interest in.
And I think the better way to look at the quit money is, you know, again, I look at it hospital-wide because I'm a competitive person. I want to hit the numbers that we dictated that we should hit. But forget about that. Let's look at it as county money, right? Whether it's 36 going to the FQs and 64 going to the hospitals, what we left on the table was 20 million county money. It doesn't matter who it goes to. It's $20 million to the healthcare system, to our own healthcare system. So if we look at it from that perspective, it takes away whose it is, because really it's overall the counties.
This MOU committee, Greg, will they be involved with the hospital-specific MOU between the clinics and the hospital?
I think all the 3 foundational documents, so the bylaws, which are the 501c3, the co-applicant agreement between the county and the SJ Health, as well as what you just specifically mentioned, Abe, that side agreement. Because I think one of the desires of prior SJ Health leadership was to do a new base year and a new PPS rate. And part of that was ramping up, change in scope. But our finance team was proactive with DHCS, because obviously a new PPS rate, given that we have to wait for the hospital CMS cost report to close, we would be 5 years out. But that MOU that you're specifically talking about, some of those cost shares are kind of arbitrary. They might be correctly accounted for, but as far as going through a DHCS audit 5 years out, some of them might not be allowable expenses, so there's a great deal of jeopardy. So the rebasing of new PPS rates has basically been off the table. But I think everything in that MOU needs to be looked at. What is proper? Should it be labor on the hospital side versus SJ Health side? A lot of these are 40% of X department. That's not the best allocation methodology.
I want to call out really important, because there's 2 sides to it. There is an opportunity for us to collect more public funds. But if you look at it from an overall performance perspective, which I think is what we're talking about here, right? We're not just talking about our current performance, but how we can do it better. Really important to understand that when the clinics were under the hospital, it was a $21 million spend. That was the cost of the clinics. It's tracking 2 years later at $48 million. And I don't know what I need to do to make everybody say, damn, that's 2.5 times what it was prior to being with the hospitals. And I say that on both sides because on the hospital side, we didn't reduce any staff when the clinics left. So there was no savings from that going over. So this is 100% increase in cost, and the increase in cost is sitting somewhere in 2 years over 100%. And it's concerning to me as somebody involved in the medical field to see that kind of cost escalation and nobody can really point out where that cost came from, but I can tell you it came from all those external contracts. So that should be concerning to all of us. The cost as it tracks, as you saw it right now, is running at about annually $48 million. Under the hospital, it ran at 21. That's a significant difference that we should all be a little bit concerned about.
And we are going to be moving through our budget cycle after we get through our HRSA operational site visit next week. I would admit that there are some opportunities on the cost side, but I think we did not double our cost. I think and it's maybe something offline Chris and I can talk about, but I think looking back, it wasn't 20 to 48 million. We definitely increased by 10 to 12 million.
Thank you, Greg. Were there any other questions or comments for Mr. Diederich? Okay, we'll move on to public comment. Is there any member of the public that wishes to address the committee? Okay, moving on. We have committee comments. I just have one committee comment. I just wanted to acknowledge that sitting to the left of me is Annette Rivas. Some of you may know Annette from her time in Human Resources, and she has joined the County Administrator's Office, so she'll be helping with the committee moving forward. You'll see her as a familiar face. Are there any other committee comments? Mr. Diederich.
So everything recently with my side hustle at SJ Health has been the on-site visit, which is next Tuesday, Wednesday, Thursday. We did a mock on-site visit in early December. Been closing a lot of gaps. One of the big ones was we were say grossly non-compliant with the HRSA deliverable to provide a scope of dental services that was not being provided. So last week or maybe a little bit before that, we signed an agreement with community medical centers to provide a scope of preventative dental within our French Camp site that will also allow us to refer patients to true dentistry within CMC, but our goal ultimately is to bring some of that scope in-house. I think last time I reported of the 92 measures, we had some exposure in about 34 of them. I think that's dropped down to maybe half a dozen at this point in time. The other things we brought on board, we are finalizing a chiropractic agreement to bring in a chiropractic service within the French Camp, and I think that will actually lead some net margin on the table as well as an expansion of services. I mentioned bringing on board some locum providers in a partnership with the health plan to help support that. But also, after the prior CEO resigned, the COO also resigned, and I know I introduced Ruben Pettiford to some of the members today, but we have an interim CEO sitting to the left of me. He's now coming up on 2 hours on the job the first day, but I'm very thankful for this to be an opportunity for us to streamline and improve some customer service aspects within the clinics. Thank you.
Thank you. We're excited that you're here. Any other committee comments? Okay, then we can move for adjournment. Our next meeting is February 21st of 2024. We are ending at 9:40. Thank you, everybody.